And so with that, I'm going to pass on to our first presenter, Shun. Is the head of our RSSH Resilient and Sustainable Systems for Health department, and he will introduce this session. Thank you.
Thank you, Marcela. Good morning, good afternoon, and good evening, everyone. As Marcela introduced, I'm Shun Mabuchi. I'm the head of RSSH and Pandemic Preparedness and Response. I will cover the introduction and hand over to Estrella and others for details. If you go to next slide, please. And next, yes, starting from a big picture. As you are facing this every day, global health financing is experiencing a very drastic change. External funding, including for HIV, TB, and malaria, is declining very rapidly. The replenishment of the Global Fund for the Grant Cycle 8 was very successful in the current context, but we still have less money than the Grant Cycle 7. So in this context, the Global Fund is making significant shifts in the way we support countries in Grant Cycle 8. The 5 main shifts are here. 1, accelerate the path to self-reliance based on countries' income levels and disease burden. And 2, rigorously prioritize investments and value for money with what we encourage and what we discourage clearly in our information notes for HIV, TB, and malaria and RSSH. And 3, prioritize populations that are more at risk. And then advance access to game-changing innovations. And then integrate HIV, TB, and malaria services into countries' primary healthcare and broader health systems, which is a focus of this webinar. Next slide, please. I will share a few high-level messages on integration here. Starting from the context in the middle of this slide, given the drastic change in global health funding, funding HIV, TB, and malaria as siloed vertical programs will no longer be sustainable. And many countries are already accelerating the integration of HIV, TB, and malaria services into primary healthcare and broader health systems. So we see integration as a means to protect and sustain gains against HIV, TB, and malaria, as it can bring long-term efficiency, sustainability, and pragmatic outcomes. And integration should be accelerated where it makes sense, based on the specific country context, as it has also risks. Next slide, please. And integration can mean many different things. So what do we mean by integration here? This slide shows country examples already funded through our grants for you to have a good sense of what kind of integration we are aiming to see more in the next cycle. So I'll pick a few country examples. On service delivery integration on the left, Afghanistan and Mongolia are integrating TB and HIV services into the package of basic health services. This resulted in rapid increase in TB case finding and other services. And on human resources for health integration, in the middle, Kenya, Tanzania, Nigeria are investing in pre-service education of health workers on HIV, TB, and malaria services in antenatal and postnatal care. And in Zimbabwe, country is operationalizing its human resources for health compact that transitions externally funded vertical roles into the government payroll based on the harmonized payments mechanism. And on the health systems integration on the right, Philippines, the second example, established integrated data warehouse and data dashboard that covers 22 notifiable diseases, including TB. I hope those are good examples to have a sense of what integration means here. And next slide. So how can countries use our Grant Cycle 8 funding to shift toward integrated primary healthcare that includes HIV, TB, and malaria services? A few suggestions as you prepare for the funding request. First, plan now with all key stakeholders under the Ministry of Health leadership and identify integration priorities for your country. Timing is now for you to work with the ministry leadership and CCM to optimize funding across disease allocation through integration. Second, in this cycle, we require countries to submit all funding requests for eligible disease components and RSSH in the same window. We also encourage countries to submit a single multi-component funding request if it's feasible for you. Third, adjust implementation arrangements. For sustainability, we encourage a national PR and SR and CSO as needed, particularly for key and vulnerable population, and common program management unit within the Ministry of Health where it's feasible. Lastly, use financing levers that promote integrated service delivery based on your country context. So this is a very quick overview of what we mean by integration and what we are looking for, and some suggestions for the next funding cycle. But I'll hand over to Estrella, who gives more detailed information on the integration. Over to you, Estrella.
Thank you, Sean. Hi, everyone, and thank you for joining the session. My name is Estrella Lazari, and I'm Senior Integration Specialist within the RSSH team that Sean leads. And I will go over the integration brief that, as hopefully many of you have seen, was published alongside the core guidance in late last year. Next slide, please. So the integration brief is part of a consultative effort with partners, with countries, and with communities to include efforts on integration and how to leverage global fund investments towards integration. It includes country experiences, although country names are not mentioned, but a lot of the examples and as well as some of the examples that Shun shared come from specific country experiences. It's not exhaustive. It's as Shun has also mentioned, integration needs to be country specific and adapted to where the country is at and both nationally and subnationally. So the examples are not exhaustive. But this is a living document. So what we will want is to collect examples as countries move forward in implementing integrated approaches. There are multiple documents referenced, including WHO guidance, extensive WHO guidance addressing primary healthcare and disease-specific integration, as well as health system integration per pillar. And there are several practical tools referenced, such as the WHO cross-programmatic efficiency analysis and the SPDI tools. And there are colleagues online from WHO who can later answer questions on these tools. There's also a tool on health campaign from the Health Campaign Effectiveness Coalition that addresses campaign integration. And there's also the Path Integration Primer, which are referenced, which are all useful tools to help countries with integration approaches. As you will see, this doesn't come as a standalone guidance. There's wording on integration in the rest of the Global Fund GC8 guidance, including the information notes and technical briefs. And again, this is a living document, so we will be adding information as we collect information throughout GC8. Next, please. So as you have seen, this is an image that you've seen. Those of you who have read the brief have already seen it. We're focusing integration on several principles. So first is country ownership, as integration needs to be country-led and aligned with where the countries are at, with the Global Fund becoming an enabler to move country-defined priorities. The approaches need to be differentiated and based on local context and disease burden, and also on the available and financial resources, both domestic and from external donors. Financing should be there should be a focus on financing for impact and support quality and efficient and sustainable integration, but also to be able to measure how integration is being implemented and what is its impact on health outcomes. This is not a standalone effort and should happen in partnership, as I mentioned before, as a lot of the integration activities will be out of the Global Fund scope, but should fit with country priorities. Communities should be engaged and should be an active partner, both in designing and in also monitoring integration as it gets implemented. And it should follow a right to health approach, ensuring that that it promotes equity and accountability, and that it's scaled to balance short-term grant goals and long systemic reforms. Next, please. In terms of planning for integration, so we have separated this in the brief in several steps. But of course, as I mentioned earlier, it will depend on where the countries are at, and as some of these steps will already have happened within your country. So first should be country defining its integration priorities and scoping existing efforts and opportunities for integration of HIV, TB, and malaria. There are multiple documents that address this, and multiple efforts that have happened in countries like national integration plans, like Every Woman, Every Newborn plans, and national health sector plans that address integration, as well as national strategic plans where integration has become front and center within the current reviews. There are maturity models to assess health systems integration. Some have been developed by the Global Fund, but some have been developed by countries or by other partners. And then there are tools that help assess gaps and opportunities, such as the previously mentioned WHO CPA tool. Ideally, an inclusive country dialogue should happen upfront and should help define the key priorities for primary healthcare and people-centered approach. But countries should also be thinking of what to deprioritize while safeguarding access to populations that need it most. Next would be to plan for sustainable integration through policies and institutionalized integration, and defining a package of essential services. And the SPDI tool can be very helpful in defining those packages at the different levels of care, and within the health systems as well. Integration should also be embedded in subnational processes, and within the country dialogue, actors from the subnational parts of the health system should also be included to better define what strategies should be adapted. SOPs and protocols should also be adapted to include this integration approach, and to support sustainable financing. There are health financing strategies such as budget harmonization and alignment to strengthen public financial management. Digital and AI investment should be planned holistically. We know that countries are at different stage of integration, and we encourage countries to plan and leverage integration using Global Fund grants. As I keep coming to the integrated country dialogue, but it's important that within that country dialogue there is a broader set of actors that can help define what the integration priorities are, and of those priorities, which one should be included within GC8. Shouldn't already mention this, but this has been a question that has come up repeatedly. So in grant cycle 8, each applicant is required to submit all funding requests for eligible disease component in RSSH in the same window. And we encourage submitting single multi-component funding requests and integrated funding requests, as this will help in coordinating across programs and with the different health system pillars. If it's not feasible, then separate funding requests are still allowed as long as they are submitted in the same window. You should earmark investments for RSSH to support integrated services and focus on primary healthcare for service delivery, and ensure an integrated approach within the RSSH modules. This will mean that we encourage programs to discuss and to coordinate how HIV, TB, and malaria will services within the health systems will be defined within those RSSH modules, so that it's not a separate HIV, TB, malaria investments, but they're defined as investments as a whole for each health system. Shun has already mentioned reflecting integration and the implementation arrangements, ideally and where possible through MOH or through national partners, and in COE settings, engagement with the humanitarian cluster is encouraged. Integration should not only be reflected in the funding request, but it should also come in grant-making outcomes, and it should be reflected in the narrative and in the budget. And where possible, we should be monitoring integration processes and outcomes. I'll mention later, but there will be some Global Fund indicators, but where countries have possibility or where countries are already monitoring, it would be very useful to mention this within the funding request. Common PMUs across donors are also encouraged, as this will help with ensuring that there's dialogue and that there's coordination, and then using financing as a lever for integration. Next, please. So we've somewhat artificially divided integration into two main focus areas. So one is service delivery, and the other one is health systems. Although there's a lot of overlap between both. So when we talk to malaria partners, malaria is often identified as very well integrated into primary healthcare and in high transmission and moderate transmission settings. But there's still a lot of work within the health systems integration to ensure that there's coordination with other programs. HIV, TB prevention and care should be integrated, and there have been multiple efforts to ensure this within the Global Fund, but also across partners, including WHO, who has merged both departments into one. HIV integration into primary healthcare and outpatient departments as it makes sense according to the epidemiology. And of course, we're conscious that integration will look very different in high burden HIV settings and in lower burden HIV settings. TB near point of care diagnostics are a great opportunity for more TB integration closer to patients and within primary healthcare. An ANC platform is a low-hanging fruit for integration. There have been many efforts done to ensure integration within ANC, but there's more that needs to happen to ensure that HIV, TB, and malaria are integrated within the ANC platform and also support better outcomes for pregnant women. And then strengthening referrals across the health systems will be important, as well as integration of campaigns, of malaria campaigns with other malaria campaigns, ITNs and SMC, for example, but also with other disease campaigns. Next slide, please. So here I will go into some examples of health system integration. I won't go through the whole slide. It's a very busy slide, and apologies for that. This is more further addressed within the technical brief. But in human resources for health, for example, optimal deployment of a polyvalent workforce is recommended. For example, training clinical staff at primary healthcare for TB treatment initiation with remote specialist support, similar to hub and spoke models that are very common for HIV, for example. In lab systems, integration of sample transport would be is encouraged through a single MOH unit that can help coordinate and harmonize budgets, for example, for laboratory systems across donors. In health information systems, interoperability of data systems is encouraged. And for example, including data hubs that host multiple sources of data and ensuring that data. Another one is ensuring that data for microplans and population denominators is used across programs, so that it can be to ensure more sustainability. In supply chain systems, patient-centric multi-channel approaches of supply chain design are encouraged, and including commodities funded through different donors and public budgets. Community systems are very related to HRH, but for example, integration of community-led monitoring into health systems to understand and to monitor integrated service delivery, quality, compliance, as well as barriers to access. And in health financing, strengthening financing systems by integrating HIV, TB, and malaria budgets into domestic budgets, into domestic financing, and using joint planning and budgeting that is aligned with public financial management systems. Next slide, please. Integration, and this was a question we received today as well. Integration enables global fund investments to go further, increasing coverage while creating efficiencies. But it's not only about creating efficiencies, it's of course, the main objective is to increase people-centered approach and improve health outcomes, even if in a lower funding scenario. There are several activities that will increase those outcomes, and others that will increase cost savings and efficiency. Improved health outcomes will come mostly from the integrated service delivery, as populations can access health services in a more streamlined approach. And cost savings will come mostly from increasing integration in health systems. Next slide, please. But integration comes, of course, with some risks. We've tried to include the main risks and mitigation strategies within the brief, but of course these will not be exhaustive, and some will need to be adapted to your. They will all need to be adapted to your context. So there are risks in having the initial upfront costs, such as training, digital systems, and expanded health products or community engagement, as well as increased out-of-pocket expenses. Some mitigation strategies for these will be to ensure that there's sufficient budget for those initial integration investments, to ensure appropriate coordination across programs and health systems, and to ensure that there is costing of integrated activities, so that expectations can be managed, and so that decisions can be made on whether some activities should continue in the same way or should be adapted. There's a risk of diluted quality for HIV, TB, and malaria, and for other services if health workers are stretched out without adequate training or manageable caseloads. There's also risk of stigma and discrimination, reducing tailored prevention and care activities for key and vulnerable populations. In terms of mitigation for this diluted quality, some strategies are to implement gradually, to provide the grounds for learning and for adapting. And again, this goes back to the monitoring recommendation I mentioned earlier, as it will help with decision making. Support transition with task sharing reforms and pre-service training. Shun has already mentioned some examples of countries that are already doing this and have already successfully implemented these. And adapt services to ensure patient confidentiality. Fragmentation is another risk, siloed budgets, vertical program structures, and resistance to change. But the reality is that there is less funding, and we need to do more or the same with the same amount of with less funding. And so there is a need for that change. So there's identify in order to mitigate those, you can identify existing integration opportunities that can serve as a catalyst, showing and championing where there is possibilities for integration and how it can improve those health outcomes. Also considering how those subnational governance structures can need to adapt to reflect joint planning and shared accountability. And last, there are some equity risks that come with integration, as some models may unintentionally exclude or underserve marginalized populations. For that, you can ensure a community engagement, including the populations most at risk in the design, the planning, and the monitoring of activities, and also some tailored approaches such as social contracting and community-led monitoring. Next, please. I will address this a little bit further in the next slide. So some mitigation strategies for integration of HIV population service, key population services that can be included in the initial strategy. So The main risk will be decreased availability of those services. But as mentioned earlier, consultations with KP populations and people living with HIV, again, in the design, and also in the design, in the implementation, and in the monitoring. Implement services gradually and integrate services gradually and monitor repeatedly. CLM, as I mentioned earlier, is a way to do this. Stigma and discrimination in facilities will require inclusive training of all staff within health facilities to prevent stigma from happening. And KP and personal data access by government entities. And it would require, in contexts where barriers to service exist, to preserve KP availability to access HIV care anonymously. And then loss of some KP services. And for this monitoring either through CLM or through skills audit and to help facility staff to help identify those gaps. There are other populations, other vulnerable populations for who may have barriers in access to care. And for those, activities such as the Malaria Matchbox or other TB activities can help guide where those barriers are and how to mitigate the access to care. Next, please. So the Global Fund is developing some indicators to help monitor integration through a holistic framework. There's indicators developed for integration of service delivery. Some will be custom indicators, part of work tracking measures that address country policies for integration, whether those policies are being funded, and then whether they're implemented. We won't be able to measure through these quality of service or equity. There are maturity models available, both from the Global Fund on laboratory, community health workers, supply chain, community systems, digital, and HMIS, and there's one on early warning surveillance that's being developed. But there are multiple tools available and country-specific tools that are also available. We're also using some internal processes for integration to assess where integration is at and how it's being implemented and it's being reflected in GC8 funding requests. Next, please. Okay, next I will pass to my colleague, Jessica Kraus, who will present on levers for integration. Thank you.
Thank you so much, Estrella. My name is Jessica, and I'm a specialist in strategy, also working within the Resilient and Sustainable Systems for Health team in the Technical Advice and Partnerships Department at the Global Fund. For those who just joined, a note to participants to please continue to put your questions in the QA section in Zoom, and we'll take them together at the end. We're now switching gears from the more technical aspects to providing an overview of the broader set of activities being undertaken to advance integration in Grant Cycle 8 by the Global Fund Secretariat in collaboration with country stakeholders and partners. Next slide. This slide presents an overview of the main activities. The first bucket at top of the slide is around messaging through Grant Cycle 8 materials and tools. In addition to those mentioned by Shun and Estrella, including the release of the integration technical brief, the update of the applicant guidelines, and work on development of indicators. In addition, we've updated all Global Fund information notes to reflect support of integration. The funding request form has also been updated to require applicants upfront to specify integration priorities. As Estrella mentioned, promoting more integrated approaches may also include adjusting implementation arrangements where appropriate. There are several resources available to support country teams, CCMs, and PRs with PR transitions. Please contact your country team or the email address on the slide for access to these resources. There are other documents linked to Grant Cycle 8 to be released in due course that also promote integrated approaches. These include budgeting guidelines, the example funding request, and a new community resource being developed by the Asia Pacific Learning Hub and other community partners. In the second bucket in the middle of the slide, we've noted outreach activities underway or in the pipeline. These include holding information sessions like this one with partners in integration. Specifically, these include disease-specific meetings linked to Grant Cycle 8 preparation, such as the recently held Rollback Malaria meeting, forthcoming webinars and case studies on, for example, accelerating supply chain integration, as well as a series of community-led webinars and regional packs for communities and civil society groups on Grant Cycle 8 that will touch on integration. Importantly, over the coming months, we're also working closely with the CCM Hub to reach CCMs through upcoming trainings and learning materials on integration. In the third bucket on the bottom of the slide, you'll see additional efforts related to the funding request process. We are promoting country-led sessions within country dialogue or similar approaches for clear identification of strategic integration priorities. We're thrilled that Benin Ministry of Health representatives have joined us today to discuss their approach in more detail. There will also be regular Secretariat advisor support to funding request development on integration, and integration is also planned to be considered as part of the funding request review and approval process. It's important to note that not all these levers may be applicable for all countries and partners, but I hope that this slide gives you a sense of some of the activities that you are likely to have seen or will expect to see in the coming weeks and months. I'll now hand back to Australia to introduce our speakers on applying integration support and practice in Benin. Thank you.
Thanks, Jessica. Just mention, Benin will be presenting in French. So if you want to listen to this presentation in English, ensure that you're on the English interpretation channel, not the original audio. And I will now switch to French to present the speakers from Benin. On est très heureux d'avoir l'expérience.
We are very happy to have the experience of Benin to present their activities and their experience on integration. We have online Dr. Herbert Bekmoude, First Executive Secretary of the National Board for the fight against the 3 diseases, Dr. Conrad Guénon, Direction of Community Workers at the Agency of Primary Health Service, and they're responsible of the strategic national instance of the coordination for the Global Fund. Thank you very much. I now give you the floor. Thank you very much indeed, Madam President. Ladies and gentlemen, people responsible of the Global Fund, representatives of our governments, of partners, and international organizations of the civil society, and the government of Benin and the Minister of Health in Benin, President of TNLSPP, would like to express their gratitude to the Global Fund for this strategic initiative. This is a great opportunity given to our country to present our experience through this presentation carried out by 3 people, 3 voices. Benin wants to illustrate a clear vision and a collective dynamic of integration. Suivant.
Merci. Our
intervention is divided in various points. I will present first the process for developing the National Integrated Strategic Plan 2024-2030 against the 3 diseases. It's called NISP. So this is the national plan that we have. These modalities of implementation and the follow-up services will be tackled also. Our 2 colleagues are going to speak about the alignment of the INSP with the National Community Health Policy. And finally, the country's prospects in Benin within the framework of CS8 in relation to the National Workshop on Service Integration.
Next. Quelle est la vision
What is
de
the
notre
vision
plan?
of our plan, national plan, the plan 2024-2030?
Il expose une
There's a
vision
vision,
transformatrice, à
there's a
savoir,
transforming
à
vision,
l'horizon 2030,
i.e., by
le
2030,
Bénin
Benin
renforce
will
sa
strengthen
plateforme de
its
gouvernance
integrated
intégrée
and
et
effective
performance
governance
à
platform
vitesse
for the
nationale et
national
maladie
response to
prioritaires
priority diseases,
qui tient compte des enjeux
taking into
d'égalité des
account
genres et des
gender
droits humains
equality and human rights
et
issues,
assure
and
la
ensuring
synergie et
synergy
l'efficacité
and
dans la lutte
effectiveness in the
contre
fight
ces
against
maladies.
these
Cette
diseases.
vision
This
traduit un
vision
changement de
translates a
paradigme, à
change,
savoir
a paradigm shift,
passer d'une
i.e.,
juxtaposition
going
de
from a
réponses sectorielles
juxtaposition of
à une
sectorial
logique
responses to a
systémique
systemic
centrée sur
logic,
les
which
populations.
is focused on
Next.
the population. Next.
Parlons du processus
Let's talk
d'élaboration du
about the
plan.
processes of the process for developing the
Dès
plan.
2016,
In
le
2016,
gouvernement
already the
béninois
government
a
in
affirmé
Benin
une ambition claire
asserted a clear
de
ambition
capitaliser
to
sur la maturité des
capitalize on the
programmes de lutte
maturity
contre les
of
maladies
programs
prioritaires
fighting against priority
afin de
diseases
permettre
in
leur
order to
intégration
allow their
pour plus
integration
d'efficacité.
for more efficiency.
C'est sur cette base
On this
qu'a
basis,
été élaboré le premier
the
plan
first plan, 2024,
2020-2024
the first one was
ainsi que
2020 to
celui en cours
2024,
actuellement
and the next one, 2024 to
2024-2030.
2030. That was the
Le
spirit.
processus a été
The
conduit
process
selon un
was carried
principe
out according
fondamental
to a
d'adaptation
fundamental
nationale sous
principle.
le leadership
It was the
politique du ministre de
participatory
la
and inclusive
Santé
principle led
et
by the
avec une
state, with the
coordination
leadership of
technique
the Minister
assurée
of
par le
Health and with the
CNLSTP.
technical coordination carried out by the
L'élaboration s'est vraiment
CNLSTP.
appuyée sur un
This
dialogue pays individu
implementation was
et
based
structuré
on a
associant
structured
les programmes maladies,
country
les
dialogue.
sectoriels du One Health,
We have
les
the
programmes
different
sectoriels
programs,
au
the
sein des
sectorial
ministères, les
programs
partenaires
inside
techniques
the
et
ministry,
financiers,
the
les organisations de la société
financial
civile et les
sectors,
communautés ainsi
disease
que
programs,
les
One Health
consultants
sectoral programs, PTF, civil
avec
society
une
organizations,
analyse
communities,
conjointe des réponses
in the
et
country
des
dialogue, plus
indications
a
des
joint
points
analysis of
de
responses and points of
convergence. Ce
convergence.
processus a
This
également
process
capitalisé sur
capitalized
les
on
enseignements issus de l'évaluation du
the
plan
lessons learned out of the
2020-2024
variations of
à
the first
travers
plan,
une analyse documentée
2022-2024,
approfondie
through
et
a
une interprétée
documentary, a
ciblée
deep documentary
avec
assessment
des acteurs clés.
with key
Next.
actors in mind. Next.
Parlons des modalités de mise
Let's
en
talk
œuvre
about
et des
implementation
mécanismes
modalities of the plan
institutionnels.
and institutional
La mise en
mechanisms.
œuvre, elle
The
repose
implementation
sur une
is based
architecture
on a
institutionnelle
clear
allant du
institutional
niveau
architectures
national
from the
au niveau
national level
communautaire.
to the community
Le
level.
CNLSTP
The
assure un
CNLSDPP
rôle
has
central de
a central
coordination
role for
stratégique,
strategic coordination,
garantissant la cohérence
guaranteeing the
interprogramme, tandis
interprogrammatic
que les
coherence.
structures
But
sanitaires et
the health
communautaires
and
et
community
aussi
structures
territoriales
and
portent
territorial
la mise en
uh,
œuvre opérationnelle
bodies are
des
part of
interventions
this
intégrées.
integrated
Cela
program.
permet de
This
concilier
allows
l'intégration,
to
la
reconcile the
proximité des
integration,
soins
proximity of
et l'implication
healthcare
des
and
autorités
the
locales, secteur
implication,
privé,
involvement of
organisations
local
communautaires
authorities,
et une
communities,
responsabilité clairement
and
définie à
the
chaque niveau.
responsibility at each
Sur le
level.
plan opérationnel,
On the operational
l'intégration se
plan, the
traduit par
integration is
la
translated
convergence
by
des services
convergence
de
of
dépistage, de prise en charge
screening
et des
service,
activités communautaires
health and community
en cohérence
activities
avec
in
la politique
coherence
nationale
with the
de
national
santé communautaire
policy for
qui
community
intègre
healthcare, which
un paquet de
integrates a
services en
pack
santé
of
humaine,
human health
animale
services and
et
for animal
environnementale.
and
Le
environmental health.
GC7
The
a été
GC7
utilisé
was used
comme une phase de
as a
transition
transition
géométrisée
phase
avec un principal récipiendaire
with the
unique
main
pour les maladies
beneficiaries
prioritaires et le
for
renforcement du
the
système de santé
priority diseases,
assuré par le
the health
CNLSTP
system strengthening with the
et avec
as RPS, and with integration, the cross-sectional integration with its 3 different dimensions, with different phases. This stage allowed us to test, to reinforce the abilities of the partners through integrated supervision. This corresponds to a solid basis for the optimization and the structuration of integration according to GC7. The best integration program is now on. Next. Let's talk about monitoring and the evaluation system and continuous performance improvement. The strategic pilot for the integration of these is based on the monitoring and evaluation system, which is harmonious and it is anchored in our national plan. This contributes to establish the routine assessment, monitoring, and the joint review of integrated assessments that allows us to do a systematic use and structured use of data in order to focus our decisions. And there's an integrated reporting in the CLSP at all levels. There's routine performance monitoring, periodic joint monitoring, and use data to guide decisions. There's always accountability with consolidated reporting to partners and periodic epidemiological bulletins. These mechanisms contribute to a continuous dynamic to improve performance and in order to reinforce and strengthen the quality of the professionals. Next.
Alors, qu'en est-il de l'alignement donc de
What about the alignment in the national plan with the national community health policy?
Cet alignement se fait autour d'une vision commune.
Here we have a common vision. We have what we call a shared One Health vision. The goal is to improve health indicators by integrating the 3 types of health, and that is human, animal, and environmental health, and as a governance framework for disease elimination, aiming to break down vertical silos. So we have 3 other structures. Integration of community actors, which are called community relays, and qualified community health agents. So this is for the prevention and awareness raising activities for the 4 diseases, HIV, malaria, tuberculosis, hepatitis, and carried out by these multi-skilled actors in an integrated way. Then we have the decentralization and local anchoring. The PNSS, that is our national plan, establishes the local health system component called COLOS as an extension of the health system at the level of villages and neighborhoods. The national plan aligns itself with this network by entrusting operational coordination to decentralized bodies and relying on local elected officials and village chiefs for mobilization. Finally, the 4th and last pillar is the single surveillance system, which is quite unique, and it's very unique in the PNSCC. This allows to establish a community-based early warning system, taking into account the 4 diseases that are taken into account by the community-based surveillance systems. It's the approach called One Health. Next. Regarding the financing mechanisms, we need to recognize that the integration allows to pool the funds and the interventions. So we have pooling and economies of scale. We can have a key strategy, which is the reinvestment of economies of scale generated by the integration and cross-cutting nature of activities. But we need the common basket fund. This common basket is established by the national plan in order to purchase health products, and also for the stock management and distribution of products. Then we have local funding and sustainability. This was one of the financing mechanisms in our country. This is one of the main features of our national plan, because we have to institutionalize the budget line called FADEC Community Health Budget Line. The national plan incorporates this approach by advocating for an increase in the contribution of local authorities to the funding of the fight or response against priority diseases. Finally, the contribution from the private sector and the civil society is fundamental to reinforce and diversify funding sources. Next. Benin has organized a national workshop on service integration led by the Ministry of Health. This was high-level national workshop. So this is the chronology. There's a data collection phases from principal recipients, disease programs, and technical departments of the ministry using a questionnaire designed by the Global Fund. Then there was an analysis of the data collected, information on areas for possible integration and suggestions for GC8 for the next funding cycle of the Global Fund. So this workshop was very participative. There were many people participating, technical departments of the Ministry of Health in charge of primary health care, laboratories and health information systems, CSOs, PRs, programs and international NGOs working in the areas of sexual and reproductive health and mental health. So there was this organization of a high-level workshop on the 20th of November 2025. There was also the finalization of responses for certain areas. It wasn't easy. It wasn't just done during the collection phase, but we needed to define and prioritize our decisions. After this high-level workshop, we have 4 deliverables. The first deliverable, first axis, is planning and HR policies. The second axis is the integration of healthcare and laboratory services. The third axis is about monitoring and assessment and the information system around it. And the fourth and last axis is about supply chain and logistics. Next. Regarding the first axis, we have 2 priorities that were defined: to have a common basket incorporating all funding, including the national budget. This action, under the coordination of the Directorate of Planning, Administration and Finance from the Ministry of Health in Benin. The second priority is to ensure the assessment of the current model for integrating grant management with a view to making decisions on its improvement for the next GC8 cycle. Regarding the second axis of this structure, that is the integration of healthcare and laboratory services, our main priority is to generalize the provision and integration of services in maternity wards in the 34 health zones in Benin. Second priority actions to sustain the integrated CLM PAC, which is community-led monitoring package, including participatory and inclusive approaches to implementation, covering the 4 diseases and the target populations. Next. The third axis is monitoring and evaluation and information system to ensure integration of TB program in the DHIS2 platform, to strengthen program coordination, focusing on integration of all areas of program service delivery,
Au niveau du dernier axe, chaîne d'approvisionnement.
The last axis is supply chain and logistics. The first priority is to achieve interoperability between the logistics data visualization system and the electronic logistics management information systems, and to implement an integrated system for the distribution of health products for all programs. Next. Next. Yes, thank you. That was the previous one. Then we need to update the roadmap for preparing the funding application to have our specific activities that have to be included in the next country dialogues. Thank you very much for your attention.
Merci beaucoup aux collègues du Bénin.
Thank you very much to our colleagues in Benin. And now you can switch to English
for the summary and the Q&A. Next slide, please. Next. So in summary, integration is a means and not an end in itself to reach better health outcomes and to sustain the gains made against HIV, TB, and malaria. It is context specific and it will depend on country priorities at national and subnational level. It is not expected to happen everywhere at the same time. And as I mentioned, it should be implemented in a stepwise approach as necessary and as relevant for the countries. The countries are encouraged to take a holistic view of the health system and the population health outcomes and address how the Global Fund investments can contribute to these, recognizing that not everything will be within Global Fund's scope. In Grant Cycle 8, each applicant is required to submit all funding requests for eligible disease components and RSSH in the same window, and we encourage submitting a single multi-component funding request. And if it's not feasible, then several separate funding requests are still allowed as long as they're submitted in the same window. Please ensure that the narrative and the budget reflect this coordination across programs, and ensure that there's a community engagement in the design, implementation, and monitoring of services. There are several questions in the chat already asking about this. And cost and monitor integrated activities to support future decision-making. So now we will move to the Q&A. Thank you there are a lot of questions in the chat. We'll try to answer as much as possible. I'm gonna start with letting Maraki, who's head of respond to some of the questions on key populations. Go ahead.
Thanks, Estrella. Sorry, we have the questions in the slides. We were going to do our colleagues from Benin first, if that's okay, because there's 4 questions for them and it flows better, and then we can call you in if that's okay.
Absolutely. Apologies, Marika. So,
thanks,
okay.
Marika.
On va passer d'abord la parole pour répondre aux questions.
Yes, we're going to give the floor to our colleagues in Benin for their the questions. Our colleagues from Benin, there are questions for you on this slide about integration and about your presentation.
The slide with the questions for Benin, so that we have them in front of us.
On les a en face. On les a.
If not, I can start. Let me see if I see them. Let me see if I see them in the chat.
Okay, Estrella, maybe we go with this slide and then we move to Benin. Sorry about that.
No, it's fine. I have the questions here for Benin. So first question from Donald Dennis Tobaiwa. Just to check if the WHO multi-sectoral accountability framework was pivotal in the integration process to support the health and community systems. Collègue du Bénin, est-ce que vous avez entendu, vous avez eu la traduction? Est-ce que les collègues du Bénin, docteur, est-ce que vous pouvez sortir le mute pour répondre?
Est-ce que vous pouvez répondre? Can you answer the question?
La question, c'est si
The question is the multi-sector accountability framework from WHO was used for your integration process in your country. We cannot see this question on the slide. Sorry. Can you hear us? Can you hear us, Benin? Yes, we can hear you. Did you hear the question? Question number 2, apparently. Question 1. Question 1 in the chat says the question. Thank you.
Sinon, on peut passer à la prochaine question, si c'est plus facile.
Otherwise, we can go to the second question if you don't want to answer this one, the first one, about the multi-sectoral accountability framework. What is the prevalence of HIV, TB, malaria, and hepatitis in Benin? Does this integration apply to all levels of healthcare, i.e. community subsystems and health units?
Okay. Je pense que les collègues du Bénin.
I think that our colleagues in Benin have problems, connection problems.
We can move to the initial questions and come back to them when they can connect. So apologies for that, but we will go to the first questions on key populations while our colleagues can connect. All right, please go ahead. There are several questions on key populations that can be on addressing key populations and vulnerable populations through integration. So please go ahead.
Thank you so much, Marcella, and thank you very much for the question. And you might have seen when Estrella was presenting, she specifically talked about this because we know that if there's a lot of stigma and discrimination in the health services, the people are at most at risk. They will, including key populations, they will find it difficult to access, and so they will not come to the health services. So that's why as we work on integration, addressing stigma and discrimination by sensitizing health staff and training health workers and make sure that stigma and discrimination is part of the standard health worker training is absolutely critical. We also recognize that this it really depends on the country by country situation, and we'll have to work with the national stakeholders to make sure that universal health coverage really is universal and that all people have access, especially the people who are at highest risk. I think I'd leave it with that, Estrella.
Thank you, Marika. And there's a lot of questions. Apologies because we won't have time to answer everything, and we will try to provide answers in writing to as many questions as possible. So next, let's see. Next, let's go to. Wait, apologies. More questions for Benin. Next, more questions on integration. So. Recommend it. I'll go to a question on. Let me see. Beyond the 3 diseases, HIV, TB, and malaria, can a country context integrate hepatitis? So a country context should integrate everything within the health system. The question will be how much can be funded through global fund grants. There are some integration of care that will address hepatitis if, for example, HIV is integrated within outpatient departments that address all needs or all STIs. There's already some work around integration and lots of guidance on integration that has been shared by the HIV team, and also integration from colleagues on HIV and on STIs from colleagues at UNAIDS and WHO. That is accessible. I don't know if any of my HIV colleagues want to include this in the chat, or any of the WHO colleagues want to include in the chat. So will the Global Fund make resources available for support of these principal long-term systemic reforms? So integration, of course, will not happen within one cycle. So a lot of the strategies that get implemented will get implemented throughout multiple cycles and in a stepwise approach according to where the country is at. But some, of course, will be addressing these long systemic reforms. There you can find the SPDI tool online. I don't know if Terry Reynolds from WHO should be available online. I don't know if my colleagues can unmute her if she wants to speak to say a few words on the SPDI tool. Terry is the unit head of clinical service and systems within WHO. If she's available online and unmutable. If not, while we do that, we can move to other tools. So on the integration maturity models, so some will be forthcoming, some will be the lab maturity model. Juste un instant, je viens vers vous dans un instant, Dr. Lé. So the maturity model, the lab maturity model, for example, has been published within the Africa CDC website, and I will be posting the link in the chat, and it will be included in the slides once they're shared. Let's see, next slide, please. So the recommendation to consolidate implementation arrangements to one project management unit under MOH are likely to result in fewer civil society PRs. So this has been addressed by Mareike, and there's some more guidance within the brief, as well as some guidance from UNAIDS to address integration and stigma. I've responded on the maturity models. I'm not sure I understand this question. If any of my colleagues understand, how about integrating all sectors of the society across the country? If any one of my colleagues want to come in on this one, if not, I'll move to the next one. For countries in transition or elimination for one disease, how flexible is the GC8 applicant guidance in allowing integrated programming across disease components in the RSSH? What evidence does the Global Fund expect to see from country dialogue processes? So this is important both for countries in transition, countries and countries not in transition. So the expectation, and there's a few more questions on country dialogue. Is that, and there's some on when country dialogue can happen and if it can happen before the allocation letters are sent. And the answer to that is absolutely yes. And it should be country-led and involve different HIV, TB, and malaria partners, but of course other partners have a broader set of partners, country partners and external partners contributing to that country dialogue to coordinate better within health systems. There is within the funding request template, there's also a space for applicants to include what integration priorities are and how they will be funded throughout the grant. So it will be important to include these integration priorities up front. And ideally, those should come from an integrated country dialogue. Let me see. Okay, so the next question I think has already been answered on integrated CLM and leveraging CLM as a way to ensure monitoring from the community. Next slide, please.
Estrella, if Mareike can come back for this question, please.
Yeah,
Sure,
now exactly. No, very, very happy to do that, Marcella and Estrella. And it's really too early to answer that question. At the moment, we are reviewing the executive order that were announced last Friday, and I think will be formally published tomorrow, but we've seen drafts. We're carefully assessing the text to understand any potential implications, and we do that in close consultation with partners and other stakeholders of the Global Fund. And also would like to emphasize that our priority will remain to ensure the continuity of life-saving prevention, treatment, and care service for the communities we serve. And I will be carefully studying potential implications. That's all I can say at the moment, given it's so recent.
Thanks, Marika. Estrella, we can continue with question
Yes.
12.
Question 12. So are any of my HIV and TB colleagues online? This has been extensively addressed within GC7 guidance as well, on HIV, TB, and prevention, which should and it's encouraged of course through WHO guidance, through UNAIDS guidance, and ensuring that where HIV services are available, TB diagnosis and screening is available, and vice versa. But if any of my HIV or TB colleagues want to come in and add, please do. Okay. Let me see. From Robert. I know the number of cross-cutting activities within RSSH component and disease-specific component can. So if I understand the question well, yes, ideally in an integrated funding request, all of the RSSH modules should include the HIV, TB, and malaria components, and be thinking more from a health systems approach. So, for example, in the supply chain module, warehousing should be united in one, and not have separate warehousing for HIV, TB, and malaria. Same, I've mentioned this throughout the presentation, but also this would mean that for lab systems and integrated sample transport should be included in the RSSH module for labs. There are some examples of this and on how to do it within the brief, but of course they're non-exhaustive, and there can be more that can be added to that. Okay, so.
Estrella, we're going to move to the questions for colleagues from Benin if they're back. So okay. Because there's several questions for them, we want to take advantage of them being here.
Yes, and we only have 15 minutes left. So, les collègues du Bénin, est-ce que vous êtes en ligne?
Oui.
Okay.
Oui, nous sommes bien là.
On va passer au...
Oui, nous sommes bien là.
Yes, we are here. We are here. Let's go to your questions here. The first question, to check if the WHO multi-sectoral accountability framework was pivotal in the integration process to support the health and community systems. You have the translation in French there. Yes, we can confirm that the WHO framework was included, yes, in the implementation of our strategic plan at national plan to eliminate the diseases, but also at the level of national policy for health and community health, which is completely integrated in the framework of this plan. So yes to this question. Thank you very much. Next question. What is the prevalence of HIV, TB, malaria, and hepatitis in Benin? Does this integration apply to all levels of healthcare, i.e. community subsystems and health units? To you. Thank you. Thank you very much. Regarding the prevalence in Benin for HIV/AIDS in general population, it's 0.8%, so less than 1%. As regards tuberculosis, the current incidence, which is validated by in the last WHO report, is 44. No, 40 cases for 100,000 cases in Benin. 40. So it's diminishing very quickly. 40 for 100,000 inhabitants if we compare with the previous years. Regarding hepatitis, hepatitis are, of course, integrated in the plan, the national plan, and the plan is called Strategic National Plan, Integrated Plan for the Elimination of HIV, TB, malaria, and hepatitis in plural, and for epidemics. All these diseases are prioritized in Benin, and they are included in the national plan. So more diseases are included in the new health and community health programs in Benin. This is included. At a community level, this is included. Talking about the levels of health care where integration is carried out. Well, the question of integration is holistic, exhaustive, at all the levels of the health pyramid in Benin, as we mentioned. At central level, we already have a political piloting program by the Ministry of Health and the other institution, CRSPE, which is doing the technical coordination. At intermediate level, everything is included, it's comprehensive. But at operational level, we can say that in the whole health structure in the country needs to cover the national plan through various actions, screening, healthcare interventions, community actions. This is included, but the community part is also included because when all the villages and neighborhoods of the country are included. So we have a national integrated plan for the whole of the territory, and it has a national dimension called One Health under a PAC, the umbrella of animal, environmental, and human health. I would like to say that this takes into account all the priority diseases that we have mentioned before with the indicators of all levels and the accountability spaces that allow to follow the implementation at all levels. Thank you very much. Next question. It's important for low prevalence countries for HIV. How do you organize screening services given that malaria screening is available in all health zones, while tuberculosis and HIV screening is only available in a limited number of screening centers in Benin? I believe that they want to know how do you organize the access to healthcare and screening apart from the screening centers. How do you organize that in all health zones? Thank you very much. As you just said, in HIV and tuberculosis, there was a clear improvement of coverage and care coverage. So you spoke about health zones for the different health facilities. I'm talking about the public ones, but the private ones too. They have technical capacities which are quite good in order to do screening. But at community level, not only talking about the CLM, but for the community follow-up and monitoring, and there is the implication, the involvement of relays, and there's a whole community pack, and everything is included, which amplifies and optimizes the screening and follow-up at all levels. Thank you very much. And now the next questions. How exactly have you integrated the integration and community actors and qualified community health workers? These are included in the remuneration budget, or do they work as volunteers? Are they included? What motivations are taken into account in their integration? Thank you very much. Regarding the community relay and community health workers, we have two types of health agents. The community relays are voluntary. They are designated by the community, but they are voluntary. They cover 200 households. And then the qualified health workers are specialists in health care. They are technicians, health technicians. They have specific roles, and they're the supervisors of the community relays who are volunteers. The integration is done on basing themselves on a general budget pack. All the community relays are organized in the territory, and they have the same activities, the same role that they deploy in the various territories. This pack is quite large, and we had to put motivational mechanisms. The community relays are voluntary people from the community. They have a motivation. They motivation have a little financial payment every month. There's non-financial motivation too. They have a bicycle to go away. They would go from one village to another. We have different mechanisms. They have a badge. They want to motivate people in a financial way. Then there is some financial motivation for the specialists, the health workers. They have a salary of 250 CFA. They have a car and non-financial motivation too. So there's an activity pack also. Apart from that, these motivations and incentives are given by the government and by technical parties. So there's a mapping, and some are covered by the technical partners and others by the government through the branch for community health, which is a budget line in the government that is directly given to the communities and to the municipalities, to villages. We need to recognize that the financing plan includes a complex allocation of the budget in the implementation project. So in a progressive way, the partners' monies diminish and the government's monies diminish. So every year there's a reduction every year. So in the last year, they will be completely covered. Thank you. Thank you very much. The last question with you, and then we have other questions to answer. When we know that the national budget is often unavailable or not always dispersed on time, when needed, what strategy has been put into place to ensure the optimal functioning of the common basket? Be brief, please, in your answer, because we have other questions. Thank you very much. In Benin, the Ministry of Health has to ensure the fluidity of the disbursements. We have what we call a pilot committee for community health. So this committee is following all these matters, and the Ministry of Health has the direct line of contact with a committee regarding the common basket. So these are priorities that cannot be postponed here in Benin.
Merci.
Thank you.
Okay, I will move back to English. Apologies for the translators for moving back and forth. And I'm going to try and compile some messages try and compile some messages as there are multiple questions. So there's been a lot of questions on access to key populations. Marijke has given a comprehensive answer on that, and there are multiple resources available that we will make sure that we include in the slides when they are shared. Also, we will answer questions in writing within the slides when they are shared, or they will be published on our website. There are questions on PR and implementation arrangements. This is the encouragement to move for sustainable integration and a sustainable approach and self-reliance, as Shun was saying in the introduction, is to have ideally national PRs and national SRs, but we are aware that this cannot happen everywhere. But it's still an encouragement to move in terms of sustainability. There are some questions around measurement and around indicators and what indicators are available. The indicators that we're making available are custom indicators, which means that they can be adapted to the country context, and the denominators can be adapted to the specific country context. And work plan tracking measures are available when custom indicators do not exist, to be able to monitor different strategies across time. So that's some of the questions I've seen. Let me see if I can answer a couple of questions before we close. And let me see. Do we treat PPR and One Health in GC8? So PPR, of course, is one of the axes for integration through surveillance and through integration of both surveillance systems and lab systems as one in one approach, and focusing not only on HIV, TB, and malaria, but leveraging, for example, malaria with acute febrile illness surveillance. This one I've mentioned. CLM, highly recommended throughout the brief. Let's see, next slide, please. CLM again. So on this one, because there's a lot of questions on community. Communities have been at the center of developing the brief and developing the integration strategies, and there have also been consultations through the community connector and through other community actors. And this will continue to happen in country. Communities, of course, should be involved in the country dialogue as well, to ensure that they're part of the design and also the monitoring and implementation of integrated strategies. There's a question on HRH and specifically on TB. And a question from Karen Zamboni, leading on health, human resources for health. As the Global Fund does not prescribe specific staffing norms, applicants are encouraged to align to country-approved staffing norms and justify in detailed budgets on HRH with clear assumptions, and engage HRH directors in determining appropriate staffing needs based on available context-specific analysis, such as workload indicators or of staffing needs. Where these norms are not available, or the country intends to review these to support integrated service delivery models, such activities would be eligible under RSSH HRH. Okay. Can you move to the next slide? But I think we're just going to have to close soon. Let me see. There are some questions on GBB and some questions on healthcare system. Since I won't be able to answer everything, we will reply to as much as possible, again, in writing. A lot of the answers to these questions are also in the integration brief, and will also be available online, as we realize that there's a lot of context a lot of content, and it's difficult to digest everything in a short time. So I want to thank everyone for your participation, for attending the chat, and please keep the questions coming. As I mentioned, this is all these documents are live documents, and it will be important to update them with country experiences. And we also encourage country-to-country learning. Benin has provided an excellent example of country-led integration. There are many other countries that are also moving to more integrated approaches and integration tools, and we encourage more exchange across countries. Thanks a lot for your participation, and have a good afternoon.